Sabine, why don't you take it away?
Thank you. Just changing here to presenter mode. So can everyone see my slides? Okay, very good. So thank you all for having me again. My name is Sabine Franklin. I'm a postdoc researcher at the MacMillan Center for International and Area Studies. I am also affiliated with the Westminster Development Policy Network at the University of Westminster. So the title is actually taken from my recently published article in the Journal of Institutional Economics. Is looking at the response of traditional and community leaders during the 2014 Ebola outbreak in West Africa. So specifically, I'm going to talk about Liberia and Sierra Leone, where I did field research there in 2017. So just kind of our agenda for today and the things that I will talk about. The motivations for this research. Then I'll give you some context about the outbreak in the countries, in case you've never heard of Sierra Leone or Liberia. Then I'm going to go into some economic type concepts such as public health goods, governance, and institutions. And then after that, as I said, we'll take a pause for clarity questions if there's any, because I know this part might be a bit hard to muddle through. And then we'll wrap up with findings and research impact. And I'll tell you just a little bit about my current research, which is in progress. So as I said, a little bit about me. I have a very multidisciplinary background in my career from nonprofit, government, and now research. So my interest in health started way back in 2011 when I was working as a health educator in Central Brooklyn for a largely immigrant community. At this point, we were focused on HIV/AIDS and, awareness and sensitization around that. But then I moved on to work for a city council, particularly in Upper West Side, which has a very similar, immigrant, low-income type demographics. Upper West Side, West Harlem, as they now call it. So that was from 2014 to 2016. So as you can imagine, 2014 was the year of the largest Ebola virus disease outbreak. It was the first time it appeared in West Africa. There was not a lot of expertise or even experience with this disease. And you might remember that in late 2014, New York City had its first case of Ebola outbreak, which is Dr. Craig Spencer, who just came back from Liberia where he was volunteering. And he, had a fever and he called the hotline and they came and removed him since he was recently traveled from that area. And of course, later on, he tested positive for Ebola. So our district city council was actually ground zero for the Ebola outbreak. Dr. Craig Spencer lived about 6 blocks away from where our office was. So you can imagine being the health, housing, and youth liaison for the city council member. We were now dealing essentially ground zero, at least in the Northeast area, with Ebola. So that experience is there, and having to deal with public relations for the legislator, where he was pretty much on the phone all day with every single news outlet, every single official from the mayor to the White House, and basically trying to do a lot of public relations to calm the community, because you can imagine everyone was afraid. And plus, with our large African immigrant community, there was a lot of stigma. There was a lot of, people feeling like they're being targeted. So our goal was really to try to, as I said, calm people, have a lot of outreach and public facing time with the community to assure them that everything was under control. So this is what led me to do a PhD on the Ebola outbreak by 2016 when I went over to London and Westminster. So the methods, just briefly, as I mentioned, I'd been on to Liberia and Sierra Leone, and I conducted 67 semi-structured interviews with a range of stakeholders. And I also reviewed epidemiology data from the WHO situational report. So the dominant narrative from these outbreak in the media, as well as even in the scholarly literature, is that aid from Western countries, kind of came in and saved the day. But my research kind of reveals a different story on the ground, a story that you can say has been marginalized in the mainstream media as well as literature. So this is our first part, where just to give you some country context. So the map on your, I guess, right would be the map of the continent of Africa. And then you can see in orange is the country of Sierra Leone, and in green is the country of Liberia. And then to the left under Dunmaid's article, we kind of just take out West Africa, and then you can see all the countries that make up what's called ECOWAS, which is the Economic Cooperation of West African States. So ECOWAS is basically like the EU of West Africa. It's a political and possibly economic integration of these West African countries. So, just to say that, first off, when it comes to maps of Africa, a lot of maps just suck. So I apologize up ahead for not finding a really good map of the different specific regions that I want to talk about. But specifically, I want to focus on the Mano River region, which is right along the 4 countries. If you see highlighted, well, it's not highlighted, but Sierra Leone, Liberia, Guinea, and Cote d'Ivoire. So this region is significant for political reasons, because it was the source of civil war in the 80s and 90s, which really destroyed the infrastructure in these West African countries, as well as the source of the Ebola outbreak. So when we talk about epidemiology of power, it really is it coincides when we see these disease outbreaks kind of afflict these very marginalized area, as well as you can see, because it's in the rural interior, because it borders those 4 countries, it is away from the centers of urban power. So the timeline of the Ebola outbreak is, the timeline that I give it is very different from, again, what the WHO and the mainstream literature calls the timeline. So the very first case, the incident index case, was in December 2013 in Guinea. And then WHO declared it a public health emergency of international concern by August 2014. Right, so their timeline starts after August 2014, right? But obviously we want to know what happened from December to August. So in order to really reflect the narrative of the people on the ground, I needed to decolonize the timeline. So phase 1 is from December 2013 to August 2014, and then phase 2 is from September all the way into the outbreak was declared an end in June 2016. Right, so the timeline, so my research focuses on phase 1. And, again, we talk about what local communities were doing, because we don't want to give the sense that they were just kind of waiting around until, WHO and other Western powers intervene. So this is the CDC map of the case counts of the 3 countries that were mostly affected. I don't know if you can kind of see my arrow here, because again, I'm trying to just highlight where that Mano River region is, because it was very difficult to find a map for it. Can everyone see my arrow? No, you can't? Okay, sorry. But if you look again at the border of the 3 countries, where you see it says Kono, Kailahoun, Lofo, and Gwekudo, right in the middle here. So those were the epicenter of the Ebola outbreak in the initial stages, right? But here, where the water is, you see CDC October 2014. That is when the CDC started counting, Ebola cases, because like I said, their timeline starts afterwards. But that region is no longer in the darkest red, right? What's in the darkest red are the coastal cities, such as Freetown, which is the capital of Sierra Leone, and Monrovia, which is the capital of Liberia. So obviously this kind of begs the question of, why is it that the epicenters where the disease started in that phase 1 is no longer the epicenter by phase 2. So this is a video that I took on the back of my motorbike. I've actually been kind of sharing this video. I've been doing science communication talks this year because I wanted to give you a sense of what it's like to be in that heavily forested region in the Mano River region, right? So as you can see, very rural. I'm on the back of a motorbike, not because I wanted to experience the wind in my hair, but because it was the only way you can get around. So this was in March 2017, which is significant because March is the beginning of the rainy season in these areas. And so as you can see, the road is not paved. But at the height of the rainy season, these roads become muddy rivers. So if you have kind of like a regular sedan type vehicle, you're not going to be able to pass through these roads. And if you pay attention to kind of the side of the road, you'll see kind of like these grooves or ditches. This is where motorbikes will have to commonly pass through because the roads are just unpassable. So just again, wanting to reiterate from this part of the world, or this part of the countries, that these are roads that have poor road infrastructure. These rural communities are physically as well as just politically disconnected from urban centers of power. So if you are MSF or Samaritan's Perf, Red Cross, any of these type of international organizations, and you need to bring biomedical supplies, or you need to build treatment centers, it's very difficult to kind of navigate logistically to go into the rural interiors, especially since again, that first phase of the Ebola outbreak coincided with the rainy seasons. So from April through July, a lot of these roads were also just logistically impossible to pass through. So now we're going into our second part, where we're going to talk about some of these political economic concepts. So this picture that you see here, I actually took, I believe, again, it was in northern Liberia, but it could have been in Sierra Leone. It's a Veronica bucket. And I see this as like a key symbol of how traditional institutions governed, right? Because this was like a social innovation. And, societies will innovate in a social way when the existing solutions do not solve their problems. So this definition of governance comes from Mark Bevere. I think that's a very, pretty good and standard definition of what we think about governance. It can be kind of formal or informal organizations where, we make decisions, accountability, managed through either the laws or regulations, or just through norms and influence or language. So when you think about a disease outbreak, there are multiple institutions that can intervene to govern, right? So we have state institutions. So this would be your ministries of health, your departments of health. So state institutions, we tend to think of as passing laws or regulations, right? So like emergency management, such as the quarantines that we all experienced during COVID, the lockdowns, social distancing. We also have aid institutions, and those are some examples there. So aid institutions will have governance patterns where they, maybe will fundraise, or they'll donate supplies or resources. In the context of a low-income countries, it would probably be more like clinical supplies or biomedical supplies, but it could also be something like food or, subsistence for people. We have private, or in economics, we like to call market institutions. So this would be like our pharmaceutical companies, some hospitals. Again, even if you think going back to COVID, especially in the middle, in the beginning, at the height of the COVID outbreak, we had some retail companies deciding to kind of switch over and produce cloth masks, right? So that would be an example of a private institution, intervening during a public health emergency. And of course, pharma companies, so, creating medicines or creating vaccines, obviously, would be another good example. And then you have various local institutions, churches, grassroots organizations, people who may not have an official way to like regulate or pass laws, but they have power and influence, right? So religious leaders can be influential, talking about the outbreak or, just raising awareness about what is going on. So the institution that I'm going to focus on is called Traditional Local Institutions, or TLIs. And I give this definition that is really just norms and customs that are governed by what we would think of traditional leaders that pre-existed the colonial era, survived the colonial era, and today are still popular and influential post-colonial era. Their legitimacy and authority is kind of rooted again in historical and cultural legacies, but they do have some governance patterns in legal forms, as well as I said, through power and influence. So this is just to put a name to the face of what we mean when we talk about traditional institutions. So from my left, from our left, you have the paramount chief, who's actually being bestowed a chiefdom by the former president of Sierra Leone, Ernest Bai Koroma. So this was back in 2016, and this was actually very controversial because it was before the elections. In the middle, you have a paramount chief in the brown shirt of Bombali Seguema, and then to his right in the red, you have the leader of the Poro Society, which is a single-sex collective for men. So they were actually making an announcement here during the Ebola outbreak to talk about stopping secret society rituals. And then at the end, you have a Sowe, which is the leader of the Sunday Society, which is the women's single-sex collective. So this is how, women would enter into this society in order to gain power and influence. So our next concept we're going to talk about is public health goods. So you can see from one end of the chart where it's very blue, biomedical resources, all the way to the other end is information asymmetry. So the best way I can kind of explain this is through the laws of supply and demand. Biomedical resources are tangible items that we would need in, public health emergency, right? So we need medical equipment, we need PPE, we need sanitation equipment, such as chlorine or the Veronica buckets, or et cetera, for people to practice, hand hygiene and just have good IPC. IPC is infection prevention control, right? And then as we kind of move left, you see that these are all about behaviors, right? So during a public health emergency, we want proactive behaviors like hand washing. To be fair, you should always be washing your hands, not just during COVID or Ebola, but nonetheless, right, we want people to, really wash their hands the full 20 seconds, soap and water, right, properly. We also want people maybe to be just kind of taking temperatures and monitoring themselves, right, for any type of symptom. We want to encourage quarantine and isolation or social distancing measures, right? So those are the good behaviors that we want. Then we also want to, go on and look at the risky behaviors, such as at-home caregiving, burials, funerals, and the lack of IPC. Now, to be fair, when I say risky behaviors, during normal times, attending a funeral is not necessarily risky, right? But we don't know from our experience with COVID that, these activities became risky because they draw large crowds. During the Ebola outbreak, these type of behaviors were risky because, as the person got sicker, they became more infectious with the Ebola virus, right? So if you're caring for someone at home who is infected with Ebola, you're more likely to also, get sick and then transmit the disease to a caregiver. Right. So sometimes Ebola is referred to as the disease of social intimacy because it was caregivers like healthcare workers or parents, family members who would get sick from it. And again, burials and funerals. So the Ebola virus is infectious on a corpse. So preparing the corpse for burial was also very risky. And then again, the lack of IPC. So I showed you that image from the 5th slide of the Veronica bucket, because in a lot of places in West Africa, you don't have piped in water. So the way that, they were to innovate socially was to have a bucket and put it out in every single healthcare center. And in the morning, they would fill it up with water, and anyone who came through would have to wash their hands that way, right? And then we go on to health-seeking behavior and information asymmetry. So the information asymmetry is an economic term that talks about the, so we assume in the market that when people have good information, they are going to, behave in a way that would reduce or prevent disease transmission. But often in public health interventions, that information is very biomedical or is not really interpreted in a way for people to understand. And so some of this information asymmetry that you see listed here in the last column had a different perception to people on the ground. So for example, Ebola is a deadly disease, right? So Ebola sounded very scary. People, their loved ones were, dying. No one knew what was happening. It was a time of fear and panic. But to be told that Ebola was a deadly disease, then people would say, well, then why should I go to the healthcare center? Right? Because going to a healthcare center, especially if you're in kind of this rural isolated community, is very costly. You have to, hire a motorbike, spend several hours on that motorbike to get maybe to a town, to then hire a car to take you to the next urban area, to take you to a hospital, only if you're going to die. So a lot of people thought, well, this is very costly. And the hospital can't cure me if it's a deadly disease. So why don't I stay home and die with dignity? Right. But then, as I said, when you go back to that third column, at-home caregiving is risky. Burials and funerals is risky. So it was kind of a self-fulfilling prophecy when you get the information asymmetry that was being given to people, because then it affected their behaviors. And that behavior is what we would call the demand side of public health goods. So just to recap, public health goods has a supply side, which is biomedical resources. You need to get equipment, get medicine, get sanitation. And we have the demand side, which is people's behavior. We want to promote, behaviors. We want to discourage risky behaviors, but information asymmetry can affect both sides of this public health goods. It can affect people's behaviors, people's health-seeking behaviors, whether people take risky behaviors or proactive behaviors. And then even when supplies are given, so even when you have MSF, Samaritan's Purse, come in with all these biomedical resources, if people don't have that information, they may not uptake those healthcare resources. So I will stop here and now ask if anybody need any clarity questions based on these concepts that I just explained.
And I would invite anybody to ask just shout out your questions. All right, while people are thinking about questions, I've got a few for you. I'm kind of interested in why the difference, your way of doing the timeline seemed to be, well, is much more comprehensive than the WHO. What do you think fuels their decision on when to say, it started and it ends? What's the difference between your timeline that you outlined in the WHO, the rationale?
Yes. So the WHO knows that, the index case started in December 2013. So they have some, insight there. But, for them, when we talk about the weekly situational reports, when they actually had their resources on the ground to see for their own eyes what was happening, that started after they declared it a PIAC. Right. So from December 2013 up until August 2014, they were just relying on, say, the ministries of health or other actors on the ground to feed them information. Right. So even the case definitions was very different. So from August 2014, the way the local ministries of health were, doing a case definition for what is Ebola, what is a confirmed case versus like a suspected or probable case, is different from the WHO standard. So even if you look at the raw epidemiology data, you'll see that it changes after September 2014, and even the collection methods change. So because the WHO has different, as I said, criteria for how they classify Ebola cases.
Okay. And now you talked about, and are you going to maybe get into this in the second part of your presentation, but about, you did a sizable number of interviews, semi-structured interviews. What was your concern, or maybe you're going to address this, on recall bias, the potential for that to have influenced your data?
Yeah, when we talk about doing interviews with people, there are some weaknesses that I think are, normal in terms of recall bias, human memory not being perfect. And so I visited 3 different provinces in each country. So in Sierra Leone, I went to Kailahun, Kenema, and Bo. And in Liberia, I went to Lofa County, Migibi, and Montserrado County. We had various various criteria of stakeholders. So I interviewed healthcare workers, traditional leaders, government workers, to try to get as broad as a narrative as possible, right? Because healthcare workers and, NGO workers, for example, would be on the supply side of public health goods, because that's kind of what they are focused on, like biomedical resources, while like the chiefs and other community stakeholders would be on the demand side of public health goods, which is educating people, going door to door, encouraging them to go to the healthcare center. As well as I also triangulated with the literature at the time that was published, even though, like I said, there was very few literature that was published for that specific time period of the outbreak phase 1. So that was how I was able to, mitigate some of these weaknesses that we see when we do interviews and field work.
Yeah, so you had 6 regions that you went to. So roughly, I'm going to say roughly 10 or 11 per region is probably,
yes,
is reasonable for hoping to be able to get to saturation within the region even.
Yeah, so the data was pretty well saturated. So I only did field work once. I didn't come back a second time or the year after or anything like that to redo the interviews, because a lot of people kept repeating, what they thought were the strengths and weaknesses of the Ebola outbreak. So in Sierra Leone, out of the 33 interviews I conducted, over about 20 of them said that it was the bylaws, which was passed by chiefs. And then when you go to Liberia, because it was more urban dominated with Montserrado and McGivy being on the coastal areas, over, I think it was 23 interviews talked about the supply side of public health good, which was aid resources, in the second phase of the outbreak being the strength of what ended the Ebola outbreak.
And one clarification, when you were talking about secret societies, am I to understand, are we to understand that Sandy and Poro were secret societies, or were they known societies to the rest of the community?
Oh, I apologize. So when I say secret society, that's the term that's being referred to as the single sex collectives, the Poro and the Sandy. So it's not a secret. Like I think in Sierra Leone, over 80% of women have gone through the initiation of the Sandy Society, and probably about 80 or 95% of men have gone through the Poro Society. So they're not a secret. Everybody knows about them. But I think the reason why anthropologists have referred to them as secret is because their initiations and the different rituals are not open to outsiders. So like for me, I not grow up in that area. I was not initiated into the society. So, I would not be privy, to the different knowledge and rituals that they do. But they are well known. And, I think all over West Africa, everybody knows about them, whether you're inside or outside.
And I assume that if you're well known within the community, you carry some clout. You carry some clout with the community as far as things like disease prevention or disease mitigation. If you talk about that.
Yes, I mean, and that's why these traditional institutions were really important, right?
Yes.
Especially when you're in an area where you're disconnected from the state, so you may not have the same level of trust in institutions. And it's really not that different from what we experienced during COVID. If you remember from the height of the COVID outbreak, even in the United States, you've had people who were distrustful of what our politicians, whether they be at the national level or even local level, was saying about the COVID outbreak. You had people who were distrustful of, our public health officials, such as Fauci, who was at the national level, and even local public health officials, about the social distancing and quarantine orders. So, you having that local institutions intervene, people who are known to the community and who can speak to community members is very important. And one thing I did want to add, and this was actually a surprising finding. So some of you may have heard, over the years of something called female genital circumcision, or sometimes it's referred to as FGM, female genital mutilation. So this is one of the, initiation rituals that is actually performed in the Sandy Society. It's referred to as Bondo. So during the Ebola outbreak, they actually stopped the Bondo ritual because it is the blood ritual, and and obviously people were trying to be careful to prevent transmission, so they stopped it. So you think about kind of the international movement where international organizations have been putting pressure on state institutions to ban female genital circumcision, and how that had mixed results. The fact that the paramount chief, along with the SOAs and the Poro Society leaders, were able to come together and say, okay, no, we're going to stop this. So they stopped it from the height of 2014, the height of the Ebola outbreak, up into the time that I was there in field work. And in 2017, there was still a ban on all blood rituals for both societies.
Sabine, that's very interesting. I was going to ask you if the outbreak actually changed any of the rituals, and do you think that's something that's going to be short term or long term, or?
So when I went there to Sierra Leone in 2022, they still had a ban, but that was because of COVID. So it's a little weird. So I don't know what happened in between that. It kind of feels like Ebola and COVID happened right after each other. But generally speaking, when we talk about institutional change, right? So I think this is a term we're all familiar with. Institutional changes are endogenous, they're not exogenous. So again, what that means is exogenous, EXO means coming from outside, right? It's very hard to change an institution when you're coming from the outside. Institutions change endogenously, so endo, ENDO, meaning that it's the people who are socialized and institutionalized into, norms and customs of the society actually make the change. So, again, it also shows you that culture is dynamic. So the leaders of the institution, even the paramount chief, he couldn't just pass a law saying, okay, we're going to stop all rituals, because the paramount chief, who is usually a man, is not initiated into the Sunday society. So he had to consult with all the SOEs, to ask them, like, listen, we're in an emergency period, we need to put a hold on all blood rituals because we need to stop this. And they agreed, they understood, and then they put a ban and they stopped doing the initiation rituals. So when COVID happened now and the COVID emergency was declared in 2020, we saw the same or similar emergency bylaws that was passed during Ebola, passed also during COVID. The only changes were that for COVID, they asked people to wear a mask, which you didn't have to during Ebola. So like I said, when I went there again, it was still stopped. I don't know what the future holds for these blood rituals in West Africa. And that's typically because the initiation in traditional institutions in West Africa was a lot stronger than there was in East Africa. So as I said before, I gave you that number where in Sierra Leone, about 80% of women are initiated into the society, right? But in other countries, it's a lot lower. So it's still something that, I think needs to wait to be seen.
So that was one of the themes. So was that a theme that you thought about when you started the semi-structured interviews, or?
No, it was a complete surprise. It was a complete surprise. I can't remember which chief. It must have been when I was in Kenema, that a chief told me that, we stopped all the initiation rituals too. And I'm like, oh, what do you mean by the initiation rituals? And then, he told me all the blood rituals. And then one of my interpreter explained it, that it was the Bondo that they were referring to.
Thank you.
Yeah, no problem. All right, so if there's no other questions, then I'll continue on to the third part. Okay. And so the findings here are basically marrying these two concepts, right? So the demand side barriers of public health, which public health goods, which I talked about, are the behaviors, and the traditional local institutions, which I explained, have the social, political, and legal capacity in order to address the demand side barriers. And so they have the legal authority, right? They pass laws called bylaws. They pass bylaws to mandate quarantine. They pass bylaws that, you have to stop at-home caregiving and seek treatment from a medical professional, right? So this also meant that traditional healers were not allowed to do treatments during Ebola. They have the social legitimacy, as you can see in the second capital, because most people are, institutionalized into these local institutions. So they know their paramount chiefs, they know their town chief. So there's a higher level of trust when you have all these different community leaders leaders coming together and saying Ebola is real, this is the effects of the outbreak, and this is what we need to do to protect ourselves. And then the political aspect of traditional leaders. And one thing here to note is that Ebola was ignored in the beginning stages, not just by state leaders, but it was also politicized by some traditional leaders, right? So I just wanted to add that because the power and influence of traditional local institutions can be helpful or hurtful in this case of politicizing this outbreak. So although they were important during the Ebola outbreak, I don't want to romanticize them because they are self-interested political actors in the way any other political actor is. So now we move on to the comparative analysis. So I did compare both countries, and I found that the intervention of traditional leaders was more prominent in Sierra Leone. Liberia did have extensive community-led organizing, but traditional leaders weren't really brought into the fold until like early 2015. And plus the type of interventions that they did vary per location. So I would go to one neighborhood in, Monrovia, and they told me that they implemented a checkpoint to make sure that, people, no strangers or people who didn't live there come into their neighborhood. But, that was kind of the only intervention they did. But then I would go to another neighborhood, in Monrovia or McGibby County, and they would say that, oh, we did door-to-door sensitization, we checked for fevers, we passed out soap for people to wash their hands. So while community organizing was extensive in Liberia, it wasn't the same. And so when you think about all the different kinds of demand side barriers there are in an outbreak, the continuity of the type of interventions is really important. So Liberia did not have that continuity in the same way Sierra Leone did, because all the chiefs in Sierra Leone came together and passed the same bylaws. And I think that shows in the epidemiology data. So if you look at this chart here, the blue colored part of the bar is the total number of Ebola virus disease cases. And in the green is the total number of deaths to Ebola. So Sierra Leone had 14,124 total Ebola cases with 3,956 Ebola deaths. Liberia had 10,675 cases and 4,809 Ebola deaths. So this is ranging from December 2013 all the way to June 2016, so the entirety of the outbreak. So when you calculate that, that means the death rate in Sierra Leone was 28%, while in Liberia, the death rate was 45%, according to these figures provided. So Sierra Leone identified, 4,000 more EBD cases, but recorded nearly 1,000 fewer deaths than Liberia. So when we calculate this case fatality ratios, it kind of tells us a few things, right? So disease severity, right? So having, a range of 28 to 45% death tells us how severe the disease is, but it also tells us about environmental factors, such as, was there an availability of healthcare resources? What were the policies, to try to get people to change their behaviors? And in the second bullet point, you see I focus on these two things: identifying cases and early treatment, right? So the bylaws in Sierra Leone had the impact of identifying more cases, right? Changing people's healthcare seeking behaviors to get them into treatment and to get them into treatment earlier on, right? Because remember that information asymmetry that I talked about earlier, Ebola is a deadly disease. So what did that do? That changed people's healthcare seeking behavior. But now that you have traditional leaders come in and say, no, it's not deadly, we can actually prevent this. We can actually, go to the healthcare center as soon as you have a fever or a cough, and your chances of survival will increase, right? So those were the two key factors that I saw in epidemiology data that I believe is linked to the interventions that we saw in Liberia versus Sierra Leone. So basically, having this robust strategy of bylaws meant that contact tracing was more rigorous in Sierra Leone than it was in Liberia. So just the impact. So obviously, I keep saying obviously, but the main, contributions from the reason why I do this research is always from like a lessons learned, because I always want to ask people what were strengths and weaknesses, what do you think worked and what didn't work, because I want to, hopefully contribute something that can help us for next time. So this was my PhD research. I went during 2017. 2019 was when I was finishing up and writing my thesis and all of that. And then someone from Sierra Leone Ministry of Health and Sanitation contacted me, asked me if I remembered him. I said no, and I couldn't remember him. But he told me who he was, and he asked me for a feedback document. And so I created this document which kind of summarized all the different points that I had, and I gave it to him in early of 2020. I'm sure you might remember what happened in early 2020, but he was kind enough to add me to his WhatsApp group because he was starting a task force in Sierra Leone to talk about COVID, because they were hearing about it in China, hearing about it in the West. And so, that was kind of a good way for me to, I guess, learn and input in any way that I could. And this kind of leads me to where I am today at Yale, looking at COVID-19 strategies in Sierra Leone. So as I said, this is a work in progress. I went in November to Sierra Leone and, again, just talked to people about their COVID strategies and asked them to compare it to Ebola. So this time around, I interviewed 50 people in Sierra Leone in 5 districts. And my preliminary findings are showing that there was a stronger level of community engagement in information dissemination compared to Ebola. So primarily they had a head start on it because COVID started in the West, so they were able to follow it in the news and start their interventions pretty early. I'm trying right now to identify new demand side barriers. I still need to calculate the epidemiology data. And ideally, I want to calculate it to be a little more specific. So, I want to put together the timeline and look at the way the disease spread in Sierra Leone, because I think it's very different from how it's spread in Western countries. When you hear on the news that, COVID experienced 3 global waves, around the world, I don't think that's necessarily true for Africa. A lot of the people I talked there didn't say that they experienced 3 waves of COVID. And so, those are kind of the things I'm working on. In terms of, what I plan to do is, I'm going to publish obviously on COVID-19, but I also want to publish more broadly on politics and health policies. So not just focusing on the emergency period, because I am of the mindset that it is the public health infrastructure that leads to, public health emergency. So you have the general public health crisis that is happening in these countries, and not just these specific disease outbreaks. So I guess my questions for you guys. Any thoughts on what can be done with epidemiology data from COVID in Sierra Leone to triangulate with interviews? If you think that maybe I should be doing something else other than calculating the case fatality ratio. And I would also like to hear your story of blending methods and theories. So, my research design, I'm using economic theory of institution, as well as I'm using something called the CAS, which is critical appraisal skills in public health, which was what I was trained in the UK. So it's a very well-known public health toolkit for conducting research, and just wanting to see if anyone out there would also like to share their story of blending methods and tools. And my summary is, just a take-home message is that we're really taking lessons learned approach to how countries with low resources address public health emergencies. One of the surprising things, because COVID happened right after I graduated, is that a lot of these lessons, I think, have implications for Western countries, especially when we think about trust in state institutions, or when we see how disease outbreaks are politicized. So it's not something that just happens in African countries, it happens all around the world. And ideally, I want to engage in research that can translate to, teaching and policy. So, I don't just want this to stay in paper. Right now, I have worked with an organization in Sierra Leone called the Institute for Governance Reform, where we have a policy and practice group going, because I'm hoping that, some of the lessons learned again could really help countries like Sierra Leone to do better. And that's it. And here are my references. And thank you all for being here.
Well, thank you, Sabine.
I have, sorry.
Go on, Shiana. Yeah.
Okay, I have a question. The previous outbreak was around 1976, right?
For Ebola, so 1976 is when we discovered the disease, and I use that term in quotes because that is when we gave it a name.
Right.
But from 76 to 2014, there was about 26 Ebola outbreaks that we know of.
So how was it controlled in this whole period between 76 to now? Why did it become so virulent all of a sudden?
Yeah, so when I say the word virulent, I guess that's a very kind of biomedical word. So from my understanding, there was nothing that changed with, the genetics of the disease or kind of the pathology of it. It was more so had to do with location and circumstances. So if you look at prior Ebola outbreaks that mainly happened in, DR Congo, Uganda, Sudan, these areas tend to be, rural forested areas, as I explained in the top of my presentation, are like very connected. Right, these are small rural communities, and as you can remember with the video on the motor, where I was on the back of the motorbike, I had to take a motorbike from the urban center, probably about an hour out to get to the healthcare center. Right, and so these areas are like physically isolated. So if you have an outbreak, in a small rural village where nobody can really get to during the rainy period, then it kind of just stays and dies there, right? Meaning like the disease saturates itself out. So a lot of these outbreaks tend to be small, where like 100 people were infected and like 40 or 50 of them died. And the only way we know about them was because somebody heard that, their cousin and 3 neighbors and all their childhood friends died in like a 2-week period. And then they sent somebody out to investigate. And so usually by the time they hear about it, the outbreak is kind of towards the end, like fizzling itself out. And because of that experience, it was also the reason why WHO, the Switzerland headquarters kind of, I'm going to say, underreacted, because from their experience in history, these Ebola outbreaks always just started in like rural area. Maybe they just sent a small team or a small group of volunteers out, and it kind of just fizzled out at the end. It was really just a surprise to everyone to see the way that it spread to the urban areas, and just spread the way it did.
I was going to say that detection bias certainly must figure large, particularly in the beginning of, since 1994, did you say? 97? 94?
You mean when it was first,
Yes.
when it was discovered in 1976?
76, yeah.
Yeah.
So that, that awareness and that potential for detection bias must figure into this as well. Kate, you have a question?
Yes.
Hi, Kate.
Hi, first of all, thanks, Sabine. This was a really wonderful research presentation, and also, such an engaging speaker, so it's a pleasure to listen to you and learn from you. So thanks for a great presentation. So my question is a little bit. I'm trying to react to your last questions, but also things that I was interested in the context of the discussion of Ebola. So, on the one hand, I love that you're pointing out that there's all of these like demand side behaviors as you describe them that are really important to change in addition to supply side factors. On the other hand, we probably think that like it's a good idea to have like some basic minimum of PPE and all of these other supply side things too. So I was wondering, first of all, your graph on slide 17 is really like revealing. Is it possible, or is the data not high quality enough to go back to that really interesting periodization you did and look to see if, before there was more international support, was there also the gap? And like when you were only sort of maybe better at changing the demand side behaviors in this Sierra Leonean case, do you still see it? Like, I would just be interested to see what that looks like across the up until August 2014 period and post, if it's possible with the data. And on
sorry.
And then on that line of thinking, I was really just curious to get your thoughts on comparing the Ebola outbreak versus COVID, and whether you think that supply or demand side factors are more important in mitigating one disease, and what your interviews can tell you about the extent to which these previous experiences mitigating demand side problems in these countries, how did that help with maybe modifying some behaviors? I actually don't know very much about what the vaccine, and was it better at modifying some behaviors than others? So perhaps like really good at like encouraging people to hand wash and maybe wear masks in isolation, maybe not so good at getting people to take vaccines, and so I'm just wondering, which is something that wasn't part of the Ebola outreach. So I was just wondering if you could reflect a little bit on that.
Yeah, no problem. So yeah, I'll start with the first question, which was about the data. And this is something that, I remember we struggled with during my PhD when I got access to the raw data. So, we have you probably weren't online when I said it, but the case definitions for the Ebola outbreak changed in from the first phase up to the second phase, because when the WHO intervened, they said, please use this criteria to differentiate between suspected, probable, and confirmed cases. Then they also had different collection rates. So when we were trying to graph just like that first phase from say March to 2014, the way the data was being collected was not consistent in order for me to calculate the rate of change. So maybe you'd have 1 week where they were calculating it, say every other day, but then by the next week, they weren't collecting data at all. So we were able to get a graph, but it was very, it didn't really feel reliable. And then the biggest part was July of 2014, because by that point, all healthcare services had breakdown. So from what I remember, the data collection had stopped around June, and then we have about 5 weeks of just no cases. So it was a huge gap, and we just felt like it was problematic to be able to say that this data is reliable enough that we can, say that there's this many cases, this many, deaths before the WHO intervened, after that summer. So that's why, we decided it was probably best to do the case fatality ratio, where we compared both countries broadly, as opposed to looking at granular data for each specific county. Does that make sense? Okay. And so now for your second question about comparing COVID and Ebola in Sierra Leone. So that was kind of interesting. What folks were telling me, during my fieldwork a few months ago, was that the supply side public health goods during COVID was very different during Ebola. So, during they had almost like an endless amount of resources after the WHO declared it a epidemic, because you had people, you know, from everywhere, from Uganda, Cuba, United States, you know, all over Europe, come in with aid resources. But COVID was a global pandemic. So, you know, United States, UK, France, they were all under constraint with their, you know, COVID outbreak in their own countries. So they had a significantly a lot less, you know, supply of public health resources. And in fact, some areas even told me that their NGO funded healthcare services actually left at the height of the COVID outbreak. So almost like recalled their medical volunteers back because they needed them, you know, in their country of origin. So someone had given a good example of a healthcare center that was funded by an Italian NGO. And if you remember, Italy was very much impacted from like January to February of 2020. So those folks had left that area. So for COVID, it's looking like the strategy was really focused on the demand side. They really scaled down their intervention, you know, from the state. So, you know, they did not hire as many, you know, volunteers or healthcare workers to help with the emergency period. They didn't have the same level of supplies to distribute to people. So the focus was really on behavior and prevention. Now, in terms of identifying demand side barriers, which I'm still, you know, trying to do to differentiate it from Ebola, you know, one of the behaviors you mentioned was like the uptake of vaccines. So, you know, again, vaccines being one of those supplies that was very closely hoarded by Western powers, because they were the ones who were able to get front in line to, you know, put out billion-dollar contracts to pre-order vaccines. Countries like Sierra Leone did not get access to vaccines until very late in the outbreak. So what we in the global world would consider like, you know, third wave, you know, for them was like the end of the outbreak. So my understanding from the interviews was that the uptake in vaccines was really more for people who wanted to fulfill a bureaucratic requirement to travel, right? So not necessarily because they were still afraid of getting COVID, but because now that countries were opening up in late 2021 and early 2022, and you needed to have like your health card or like a vaccine in order to, you know, go visit the UK, go visit Canada. So that's why they went and they saw an uptake in vaccine, in vaccinations for COVID.
Well, thank you, Sabine. This has been really a wonderful talk. Like Kate said, you're a great speaker, but you have a fascinating study here that you did. One of the things that I was pondering is the whole distrust issue. My opinion is a lot of public distrust is a general lack of understanding of the scientific process, where we are always learning and changing, and that I get the sense that there is a desire or an expectation, maybe not even a desire, just an expectation, that when you get a decree from a Ministry of Health or from the media about, you know, this is what you should do, that it will remain that forever. Whereas we know that it's a dialogue, we learn more, we change the policies and the guidance. And would there be benefit to trying to educate the larger population of things change, that's just the nature of scientific research, is as we learn more, we may modify what guidance we provide. And
I mean, Mhm.
Would that decrease distrust if they understood the scientific process?
I mean, that's a fair question. And, the one thing I kind of want to revert back to is our experiences with COVID, right? Because the United States and Americans and other Western countries were considered to be a very literate population with, scientific knowledge. And, ideally, we would understand that, sometimes things change as, scientists begin to understand the disease more and more, but there was still distrust. So, I don't necessarily that we can kind of couch it down to, education levels, between, societies in low income countries versus, Western societies. I think it's more nuanced than that. It has to do with experiences. If you're in a rural area and, you hear, you've lived with a government that's always promising to do this, promising to do that, but they never deliver, you're going to have low levels of trust in state institutions. Right. And I think that's also the same for us here in the United States. There are people, outside our northeastern bubble, who always hear these promises from, their government promising to do this, promising to do that. But then when it comes down to it, they don't deliver. So I don't want to focus so much on just education. We also have to remember, lived experiences, of being, being governed by institutions that don't necessarily deliver public goods, whether they be public health goods or, things like infrastructure, like roads or running water, electricity, etc.
No, I think that's valid. And I certainly didn't, I was not couching this in terms of lower and middle income countries versus, Western countries like the United States or Canada or UK. I think it's pervasive throughout, and I think that the internet has a lot to do with your, there's a lot of places that misinformation or experience can drive the distrust, and it gets complicated,
Yeah.
when there's so much out there on the internet, and I don't know how to police that, but at least to explain the scientific process. Stephen, did you want to ask something?
Yes, let me say good afternoon.
Hi,
from
Dr.
Liberia.
Kennedy.
Hi, Dr. Franklin. Let me say good afternoon from Liberia. There's some pretty quick observation. One is that the issue of distrust in the health system, distrust in government in Liberia, it is not a factor of lack of knowledge in the scientific matter. That's not what it is. I think it's more of issue of issues of corruption, issues of lack of integrity in government officials, issues of misappropriation of resources in the country. So because of that, those things lead to misconception. So the misconception is that when there's an outbreak of public health emergency in a country, there's myth that those alarms are being raised by people in government to be able to secure funds from foreign sources to use those funds for the personal benefit. So these are some of the issues that are associated with mistrust in Liberia. But let digress a little bit. One of the challenges with science is that we, the researchers, we've not done a very good job in terms of integrating cultural nuances into, the pure science. And I would like to say that before the outbreak of Ebola in Liberia, even before COVID, there have been outbreaks of things maybe 100 years ago, and there were traditional models how to address them. You may say IPC now. They had IPC during those days. It was not called RPC, but they have standard operating procedures. They have guidelines how to address outbreak. They have guidelines how to treat people. But science has not played the current scientists, we've not played a very great role in terms of integrating their norms, integrating their understanding into what we do. So these are some of the challenges we need to address. So because of that, there remains a big divide between traditional practices, traditional knowledge, traditional concept relative to modern research, science, knowledge, practice, and whatever. Having said that, the last thing I'd like to point out is that I'm from Liberia. I'm not from Sierra Leone, but during the during the COVID outbreak, most of the data, I don't know you want to call that epi data, but most of the data was clinical models. So those were mostly clinical model related data that were collected, and how that can be translated into qualitative data to form a greater picture, I don't know. There were later qualitative study that was conducted in Liberia during the COVID outbreak. So biomedical data, clinical data is what we have a lot, so I just want to point that out. That's what I have to say. Dr. Franklin, excellent presentation, pretty smart. We enjoy your stay in Liberia. We hope you visit us in the future. Thank you.
Thank you, Dr. Kennedy. Thank you for welcoming me. It's good to see you again.
And Dr. Kennedy does raise some very good points. Just, I think the bottom line conclusion is it's complicated. And and I didn't mean to trivialize it or simplify it down to just, understanding the scientific method. There's a lot that goes into it. And I think probably Dr. Kennedy's, one of the things that I really resonated with is the involvement of the community, the local community, in efforts and in terminology and what would work or not work within a culture. Those are important factors that need to be taken into account for any public health problem.
Yes, thank you, Dr. Kennedy, and thank you, Lauretta.
Well, thank you, Sabine. I really enjoyed this. I think that we all enjoyed it. And I know that we've gone beyond what we normally do, but it was a wonderful discussion and fascinating research. I hope that we hear from you again.
Yes, if you recall, we were still supposed to go for that drink. I'm still going to hold you for that.
Okay, let's do it.
Yes. So when I come back, I'm leaving tomorrow for Sweden, but when I come back in June, I will hit you up if you're still in New Haven.
I will be in there part of the time, but we will either meet in New Haven or New York.
Okay.
All right.
Thank you.
Thank you, everybody.
Bye.
Bye.